First and foremost, just to introduce myself, I'm Fahar Merchant, President and CEO of Medicenna. Medicenna is a publicly listed company based out of Toronto. We are listed on the Toronto Stock Exchange as well as on the OTCQB. So just to let you know, we are publicly listed companies, so I will be making forward-looking statements, so I would caution you to read our disclosures. So Medicenna, as I said, we are a clinical stage company. The focus really in the company is to develop novel therapies, mostly around engineered cytokines. We call them superkines. And in those programs, the first program that I'll talk to you most about today is MDNA11. It's an IL-2 super agonist. It's been engineered, and I'll talk about it in a minute. The second program, that's a phase 3 ready program for which we are looking to partner this program, is MDNA55 for recurrent glioblastoma. And then as part of our superkine platform, we have a number of other candidate molecules in early stage preclinical that look at other indications beyond oncology into autoimmune disease, inflammation, etc. So the key milestones over the next 12 months or so, particularly this year, we expect to provide a comprehensive data set on monotherapy dose expansion data for MDNA11 and some top-line data on combination with Keytruda. And with bizaxofusp, as I mentioned, we're looking to partner this asset, and currently we're looking at seeking breakthrough therapy designation, getting alignment with the EMA with respect to the design of the phase 3 trial, which is quite novel, where the majority of patients in the control arm will be from an external control arm. And this particular subject will be not talked about today because we are covering more of that tomorrow at ASCO. So going back to the basics with respect to the superkine platform, the approach, as I said, is to use a combination of what we call directed evolution and yeast display to create a range of different molecules with slight modification to the cytokine itself. We are able to transform a interleukin-2, 4, or 13 into being either a super agonist or a super antagonist or anything in between. And we are able to selectively engineer the molecules so they'll bind to different receptor subtypes. And with that, I will sort of give you an example today around how we took a molecule which is an IL-2 proleukin molecule and transformed it into what it is today. So just very quickly, as I said, this is our pipeline. MDNA55, as I said, bizaxofusp is a program which we'll talk about tomorrow at ASCO. MDNA11 is where I'll talk about this program today. And this is a combination portion of the study which we have started. We'll have some early data there. This is a clinical collaboration with Merck. And then we have an interesting, another oncology asset, which is a targeted, conditionally activated anti-PD-1 IL-2 fusion protein. Again, not much of a chance to talk about it today, but we did present some data at AACR. So going back to MDNA11, I'll start with the basics here, really. For those who are familiar with the IL-2 space, know that IL-2 has been approved in the marketplace for about 30 years or so, but with it comes a whole bunch of baggage. Although it did help a small percentage of patients, including some patients that had long-term cures, it comes with concerns with respect to safety, with respect to the ability for the molecule to stimulate immunosuppressive Tregs, and also having a very short half-life, meaning that this drug has to be administered to patients in an intensive care unit for 5 days every 8 hours. And that certainly is a huge challenge. And what we've done with MDNA11 is using this directed evolution approach, engineered it so that first and foremost, the molecule switches its bias from sort of binding to the high affinity receptor here, the alpha beta gamma receptor, which is expressed on your regulatory T cells, but also is responsible for your toxicity, is engineered so that the molecule now instead binds to the beta gamma receptor, not the alpha receptor, so that you are able to selectively stimulate your cancer-fighting immune cells without boosting your Tregs and without causing toxicities, etc. So the molecule, just in summary, as you can see on this cartoon there is the IL-2 component has two portions. We have substantially enhanced binding to the beta domain, dramatically reduced binding to the alpha domain, and then finally to enhance its half-life, we have fused it to albumin, and albumin extends the half-life, plus also has the benefit that albumin tends to accumulate in tumors, in tumor-draining lymph nodes, etc. So this way we are able to deal with the short half-life of IL-2. So just to give you an example here, if you look on the left-hand side, you can see that IL-2 binds with extremely high affinity to the alpha receptor. And if you look at the bottom left, you see that IL-2 does not bind efficiently to the beta receptor, which is the receptor expressed on your NK cells, on your CD8 T cells, etc. What we've done with MDNA11 is we've completely blunted the binding to the alpha domain and substantially boosted the binding to the beta domain. So this is a big difference compared to a whole bunch of other IL-2s that are currently in the clinic. A lot of efforts have been made to somehow block alpha binding. That's been done quite successfully. But at the same time, what we've seen is that the tendency is that while blocking alpha, they also reduce binding to beta. And therefore, you end up with a molecule that's really might be safe, but eventually is ineffective. So these are the number of molecules that have gone through the clinic, that are currently in the clinic or looking to, or have completed phase 1, 2, or 3 clinical trials in recent years. And here clearly what we show is the unique features of MDNA11, this ability to selectively bind to the beta gamma domain, not bind to the alpha domain. It has, because of its albumin binding, the ability to deliver the drug every 2 weeks instead of 3 times a day. And because of the albumin, we are able to localize the drug at the tumor site. There is no pegylation liabilities. And for the first time, I would say that although there has been some signs of activity, we've been able to demonstrate durable activity of MDNA11 as a single agent. So in this trial, the ABILITY-1 trial, we are currently conducting a dose expansion portion after having completed the escalation phase of the study, where we started at the 3 microgram per kilogram dose all the way to 120 micrograms per kilogram and identified the 90 microgram per kilogram dose as our recommended dose for expansion. So we're currently enrolling in a single agent expansion cohort, evaluating the drug in 3 different populations: melanoma, non-melanoma skin cancer, and patients with MSI-high dMMR tumors. Second portion of the study is, of course, the combination with pembro. That has started, and I'll give you a bit of an update today as well. And the intent, of course, is eventually to do a combination dose expansion with pembro. So let's look at the safety profile so far. And I think I mentioned to you the dramatic toxicity of IL-2 very early on. But we can clearly see that, having tested the drug from 3 all the way to 120 micrograms per kilogram, we have not seen any patient dose-limiting toxicity, not seen any grade 4 or 5 treatment-related adverse events. Most of the adverse events were grade 1 and 2. There were some that were grade 3, but majority of them resolved within 72 hours. And what we found also was that the grade 3 liver function test elevations were asymptomatic, and they were transient. And finally, we did have a couple of patients with grade 3 hypotension, but we discovered that these patients these were patients with baseline adrenal insufficiency who should not have been enrolled in the study. So the interesting thing we found is with this drug is we use a step-up dosing procedure at the high doses, meaning that we start at a low dose, increase it, and then finally hit the target dose. And what we find is the majority of the adverse events take place during the first 2 or 3 doses when the early exposure, the patients are exposed to the drug for the first time. But as you see, as the patients receive multiple doses at the higher target doses, those adverse events decrease and they gradually become less and less uh, of less severity, but also less frequent as well. With respect to the pharmacodynamics, which is one thing that we've been able to show in the periphery, is that just as we had designed the molecule so that it does not stimulate Tregs, we are able to clearly show, first and foremost, that there is a dose-related expansion, but most of that expansion is occurring on CD4 T cells, the CD8 T cells, and NK cells. We don't see much of an expansion of Tregs as we had hypothesized with this molecule. So if you look again here in more detail, on the top left, you can see the dose-related increase in the population of lymphocytes. And on the right, you can also see that at the higher doses, what we clearly see is that CD8 T cells are the ones that get stimulated most efficiently, followed by NK cells. But the Tregs, as you can see right at the bottom here, the expansion of those are very limited. To further demonstrate that when we look at the ratio of the CD8 to Treg at the bottom left, you can see that we are seeing a substantial increase in this ratio, meaning that we are generating more CD8 cells than Tregs. And also the same thing happens with activated CD8 T cells with a CD25 positive. Again, you can see that at the 90 micrograms, we're seeing the highest expression and proliferation of those cells. So although from lymphocyte counts, it would appear that 120 micrograms is something we should pursue with, what we found is that these unique populations of CD8 T cells, etc., were peaking at the 90 microgram per kilogram dose, and therefore has become our recommended dose for expansion and continuing with that. The other thing also interesting was at the 90 microgram, the OX40 positive Tregs also increased in population. But the good thing there is that these are your dysfunctional Tregs. So this is something that we are happy to see. We then went deeper into the analysis of the population of our CD8 T cells, NK cells, and Tregs. And here what we find is we are demonstrating that we can enhance the population of stemness or stem-like cell populations. And we looked at the TCF1 marker here, and increasing stemness really improves the ability of the T cells to self-renew, proliferate, etc. We also found the same not only with the CD8 T cells, but NK cells, and similarly for Tregs. But the interesting thing about Tregs is that if you increase the stemness of Tregs, they become dysfunctional. With DNAM, which is another marker, also a positive regulator of immune effector function, again, we see a significant increase in the population of these cells. And then finally, on the top right, you can see both the effector memory and central memory T cell populations also increase quite dramatically with MDNA11 in the periphery. Going deeper into the tumor itself, we sort of looked at paired biopsies in patients prior to treatment and post-treatment. And again, there we see a similar phenomenon that we saw in systemic circulation. First and foremost, as you can see, the population of CD8 T cells, pre and post, you see a dramatic increase there, similar with the activated CD8 population and the ICOS positive CD8 T cells and NK cells. So across the board, we're seeing in the tumor microenvironment a dramatic increase in the population of the tumor infiltrating cells. When we go down to the gene signature level using a 360 gene signature analysis, what we also find here quite clearly is pre-treatment and on treatment, we see a dramatic increase in the population of effector cells in the tumor itself. So you can see that pre-treatment is virtually really very low levels of those effector T cells, whereas you find that post-treatment, that's dramatically improved. Same thing occurs with the population of your sort of T cell priming and activation. Immune cells also dramatically increased as well. So overall, we found that with these paired biopsy samples, we are able to demonstrate that MDNA11 promotes immune response and degrades the cancer-promoting pathways. So that's the key message here from these gene expression analysis. And then when we look at the more details on this and looking very specifically at different cycles, clearly what we see here is that we are able to demonstrate the population of CD8 T cells increasing, the NK cells population increasing in the tumor microenvironment, but also we can see the cytotoxic activity by virtue of the granzymes. We can see different sets of granzymes at higher levels. These are all providing us the cytotoxicity that we want to see. We're also seeing an increase in the population of memory and not only effector but central memory, and finally also activation markers as well. So that sort of pretty much covers the sort of the PK, safety, PD aspects of the study. What about the preliminary efficacy? We did present some of this data. These were actually from last month at AACR. The data from the first 14 patients. These are patients that received a high dose of MDNA11. Mainly, these are patients that received either 60, 90, or 120 micrograms. These are the patients that are part of our phase 2 expansion cohort of patients. And what we find quite impressively here is the response rate. We find that out of the 14 patients, 4 patients had PR. And what is really interesting is the durability of these effects in these patients. So these PRs, as well as stable disease, are prolonged. We can see that we have 3 patients with stable disease above for more than 24 weeks, including 1 patient with stable disease for about a year and a half. Diving more deeply into these patients, I would just focus on 2. First and foremost is a melanoma patient, or rather the first patient that I'll talk about is a PDAC patient and then a melanoma patient. So if you look at this particular patient, this is a patient with pancreatic cancer. The patient was diagnosed, received the surgical Whipple procedure, and following the Whipple procedure, went on to receive adjuvant FOLFIRINOX treatment, on which the patient progressed with metastasis to the liver. And at that time, the patient received gemcitabine and paclitaxel. And with that, the patient continued to have difficulty in tolerating that combination and went on to pembro. And after pembro, we continue to see progression before moving on to MDNA11. What you see on the left-hand side is a table gradually showing the tumor initially starting stable disease into a partial response, etc., until finally the target lesions completely disappear in this patient. And same thing happens with the non-target lesions, where the non-target lesions disappear. Unfortunately, the patient went on a 8-week of vacation, and upon coming back, the patient had new lesions that were observed. That patient received radiation for a single cycle, and that tumor subsequently, upon receiving additional MDNA11, did have a complete resolution of all the lesions. The patient remains off study. We did a recent analysis on the patient's scan. The patient remains on remission with MDNA11, which is really exciting to see. Same thing here with the melanoma patient here. We saw a very dramatic response within the first 12 weeks, with this patient showing partial response and eventually being the target lesions having a complete response. Mind you, the non-target lesions continue to shrink, but the non-target lesions are still there, so I can't really call them a CR yet. Okay. Moving on to the combination part of the study, just to let you know, we started with a 60 microgram, and at this point, we are sort of completed that portion of the study. We've not seen any DLTs, and now enrolling patients so that the patients receive the 90 microgram per kilogram dose in this group. So key message here, we're seeing a really positive activity of this drug, response rate of 29%, 50% of the patients having clinical benefit, and overall, the most important thing here is durability of the response. So we keep on, we expect to provide more data in the second half of this year at different conferences. And also, just to summarize here, Medicenna currently has about $41 million in cash. We expect, like every other company in the future, to raise additional capital or through non-dilutive means by partnering, etc. But now we have sufficient cash to take us into 2026. So with that, I'll stop and happy to talk to you later on. Okay, thank you.